like to welcome our listeners to today's podcast. A friend, a colleague, someone who has been on this podcast before, a solid voice for Michigan, former legislator, now working in the healthcare arena. You've gone from the fryer into another fryer, out of the frying pan in Washington or Lansing, now into a beautiful environment back in your home community, but you're still dancing with some of the past life you had. Very excited to talk with you today. Our guest, Benjamin Frederick, Associate Vice President at Memorial Healthcare, which is located in Owasso. I always used to call it Owasso Hospital. Why did I do that? I don't know. But Memorial Healthcare, we're going to learn a little bit more about what you do at Memorial and what Memorial does for its community. Roughly, serving a population similar to rural America in 50, 60, 70,000 people we think about in rural America, counties that are serving that we do, Hillsdale, Shiawassee, or whatever county it is. But Ben, it's always a pleasure to have you on the podcast. You bring so much insight because of your vast background. If I could hire you away, I would, from Memorial. So that to those listening from Memorial, know that they got a gem in Ben, because I've been in Washington, I've been in Lansing, and every time I go there, I often hear, Frederick was just here. And I realize that you get out a lot and you advocate a tremendous amount, and our job never ends. And you have a great position in advocacy and government relations as an associate VP. But it goes beyond that. It goes to speak to the relationships you've built for decades, and I want to get into that in just a minute. So Ben, tell us your story. What your background is for those listeners who may not have heard the podcast previously. A couple of them that you've been on. Talk about your background. What brought you to Memorial? What you do there? What is your passion? And why did you choose healthcare?
Yeah, thank you, JJ. I'm really glad to be back with you, first of all. Thanks for the invitation. I came to the Memorial position after about 21 years in the state legislative arena. I'm born and raised in Owasso, where Memorial Healthcare is situated, has been since 1921. Yeah. And was born at that hospital.
Oh, is that right?
Yes, that's right.
Okay. But not in 1921.
Not in 1921,
okay, all
no.
right.
A bit more recently than that.
Yeah, okay.
But,
all right.
I started off really doing the campaign side of legislative service back in 2002, actually, running a state race for state representative. And
were you a volunteer?
Voluntold, and but no, I was a campaign manager. I had a modest monthly salary, and you're over there 6 days a week, grinding and doing what you need to do. Come back on Sunday for worship and laundry. Yeah, and we won a very contested race, and I had the opportunity to go into a staff role, entry-level staff role at that time, and really never looked back. It was 14 years, different staff positions in the state house. Was a chief of staff in the state senate. And then locally had the opportunity to run for the city council in Owasso, served on the council, and served 3 terms as mayor, which was a real thrill in your hometown. Yeah. And when I was term limited as mayor, the House legislative seat was opening, so I pursued that, was able to serve as state representative for 3 terms, focusing a lot on post-secondary attainment, particularly for adult learners, first-time students. Okay. That was part of my own story, was that I was a non-traditional student, had not completed my college degree until 14 years after graduation, and then 20 years for my master's degree. So it was a passion of mine to match people with skills. As my service in the House continued, I was elected by my peers as majority floor leader in that final term, which was
I had heard that.
Really kind of moving the legislation in the House and doing a lot of the logistics, which I enjoyed, just directing those things.
Is that a 1-year term?
That's a 2-year term.
2-year term, all right.
I was able to chair the higher education and community college budget during that time. And what I was noticing as I was going through my time was that no matter what the policy issue was, healthcare had a piece of it. Whether it was workforce development, education, housing, a number of these issues had a workforce component. And I was increasingly working with the state association, having a good contact with Memorial back home as far as some of their specific needs, a very, very robust ecosystem that hospitals represent. And just that increasing awareness. I also had a personal situation where my father, unfortunately, was diagnosed with terminal colon cancer around the last year that I was in service. So as I was considering where I could really have my next season of service and have a community impact. At one point, I recall just going to the parking lot. I was outside of my car, looking around and just seeing every stage of my father's care represented around me in that parking lot by Memorial's offerings. We have a freestanding cancer center right there. We had the neuroortho wellness building that has medically based wellness. We had the inpatient side. Sadly, eventually we had the hospice services available to him for that palliative journey to end of life. But to think about the uniqueness and the preciousness of that in a city of 15,000, it was extraordinary.
It doesn't exist.
And that was really a spark for me, as I had some conversations at that point, that this is an entity, an organization that I'd like to dive into and give my best efforts to. Memorial was looking to get more active in the advocacy space with all the things that you're well aware of, with changes and regulations and frankly a lack of understanding as to how healthcare really operates on a day-to-day basis. And they embraced me, and we've been working. I've been part of that team for about a little over 3.5 years now.
3.5 now,
which is pretty extraordinary.
But you had a choice to make. I mean, you could have gone deeper into politics. Could have ran for Senate. Could have taken on a federal role, but you chose to stay home. And why is that? I mean, I know you had your dad's influence, but what attracted you to Memorial? You talk about service, right? But we also know that in our industry right now, we're facing a lot of challenges, and those services are being eliminated. So today your passion is based on what? Well,
I think that those that know me well know that I've always been kind of a mountaintopper type person. So I'm motivated by challenge, and there was an extraordinary opportunity in that Memorial was such a unique organization that was growing, that was dynamic, that was strong, that was independent. And I knew from a personal standpoint what it meant to have a hospital in my community of that nature, a community hospital. But to see the team and to get to know the team and to have those interactions over the years when I was in various roles as mayor or state representative, there was a certain inspiration to that, to say this team is worthy of my best efforts. And also the prospect of a homecoming professionally was pretty extraordinary. Oftentimes when you're in public life and you have to adopt a partisan label, you hope to present yourself in a way that is true public policy work. And so to be invited to take a leadership role within, a major organization in my district was a true honor. And I had to give that a great degree of consideration compared to the other opportunities that were out there. And I'm very glad that worked out the way it did. Healthcare just intersects with so much. And that was the other part of it, that healthcare has implications in some of those public policy veins on which I'd worked for 20 years at that point.
True.
We've had projects that touch on that workforce development space, that employee satisfaction space, customer service and patient care, where we're talking about how we present ourselves to our patients, public relations and marketing, these communications, these things that were all kind of areas of expertise or interest of mine, and they were all represented by that organization. And as I'm sure Hillsdale is as well, that it's a culture that invites innovation. So you can bring ideas forward at Memorial, and really embrace and run with the ball. That was quite motivating to me.
Is this a new role?
It was a newly created role, yes.
And I think since then you've assumed additional responsibilities. I think you have a few other departments that you're working with.
Yeah, I'm over the business development team that also encompasses marketing and public relations.
Which is another huge, especially with what's happening today in our environment.
Absolutely. So how we inform and persuade, how we consider growth. Also, a lot of our grant work flows up through my team now as well. So when we think about some of those opportunities. But again, that's been a part of the draw, is that the culture is so strong there. Yeah,
well, you're doing a great job, Ben. Like I said, I often get to Lansing more than Washington, but in Lansing, you're certainly a legend for the, and I say this with all sincerity, for all the good reasons. The policies that you created, the advocacy, the ability to reach across the lines, and that's important in today's age. It really is. Especially when specific parties are targeting healthcare, for example, waste, fraud, and abuse. And we're hearing a lot of some of those statements that are very concerning. You have been a solid voice for rules, so keep it up. For those who may not know you, a little fun fact about yourself, anything that you can share with us? I mean, so you're a country boy, right? Yeah. Born and raised in Shiawassee County. Yep. At the hospital you work, you just told us. And do you do anything for fun to connect with our listeners?
It was funny because I used to amalgamate the public life into so much of just what my habits and hobbies were, that my wife was kind of tongue-in-cheek a few years before I stepped away from that role to say, people have these hobby things and you should think about it. And she was being very light touch, as she often is. Yeah. But I had to dig deep, and I thought back to a junior high in Owasso and what was some things that I found interesting. And I actually took up wood turning. I actually visited a friend's shop in Pontiac and just had some time on the lathe again. I remembered how I enjoyed that.
Really?
Spindle or bowls and things like that. So I have a small cavernous dungeon basement that I have right? a MIDI lathe, and I have some little projects I work on. And I joke that, it's politicians don't get to produce much often. So to be able to make even small Christmas ornaments
tangible,
or gifts,
at least,
yes, tactile things, right? Certainly can look back with some of those projects, but that's been very rewarding. And the other item that's a kind of a fun fact is that a formative moment for me was my family's selection when I was a teen as a Habitat for Humanity partner family.
That's
so
awesome.
I'm born and raised in a Habitat for Humanity home, and I credit that as an inspiration for my own service. And I've had the privilege of being able to address Habitat International, state, several affiliates across the country now as just a motivational speaker. So that's a side passion of mine.
I did not realize that. Yeah. All right. That's a fun fact I didn't even know. Fantastic. Next time you're going to have to bring me one of these gifts.
Yes.
Like a bowl that you make or something of that nature.
Yeah. Right? I love the upcycling. I take pieces of scrap that I'll find, or they'll have a story and turn it into something tangible. I just love that.
That's incredible. Well, we have a real person in the studio, definitely. Man of many talents. And if you're tuning in today, we're going to talk about rural health care advocacy. And as an advocate, as an advocacy leader in the state of Michigan, we're talking to my friend, Ben Frederick, and he is at Memorial Healthcare, and they are doing some incredible things. Ben's insight on his topic of understanding the relationship between advocacy and good policy making and just really good citizenship and statesmanship is something we're going to talk about today to help us better understand the changing needs of rural health in our hospitals, not only in Michigan, but also across this country, and how we can lead conversations, both in the legislature, both locally at our state level, as well as in Congress, to address these specific needs of healthcare. So we'll talk about healthcare industry changes, advocacy efforts, and of course, what all this has to do with rural health. So let's jump into it. Ben, as a leader in rural healthcare advocacy, you've adopted your strategy specific to really what your community needs are. And you have responded to the changing needs of healthcare in your region. You're doing some incredible things. You've purchased some buildings. You have reached out in communities that normally did not have healthcare, looking at healthcare from a different lens. And I think we have to do that to be successful. We can't cut our way to success. We have to have a growth strategy. Your team, you've built that. Talk to us a little bit about what's happening in Owasso and in Shiawassee County in general, I should say, right? Because you're in the county, a driver. I would assume you're the first or second largest employer in the community. Talk to us a little bit about what you're doing, what's going on, what's the perspective at Memorial?
Yeah, well, first of all, Memorial, with our 1,800 plus employees, is well into that first position as largest employer in Shiawassee County.
Incredible.
In fact, we have more than an equivalent of 10% of the city of Owasso's population working at Memorial Healthcare, either the main hospital campus or now 40 outpatient sites across 6 different additional counties. So we have a 7-county touch point with that outpatient presence, which really connects all of these rural and suburban communities to that continuum of care, which it's the story of rural. It's not just a dot on the map. It's that continuum. Memorial has done a lot to, in effect, try to have some more additional control over our own destiny, where we have a brand and a patient experience that we own and we're very jealous of as far as ensuring that. So when we can have additional steps to that represented by Memorial-based entities, we try to do that. So we've had a couple of successful Rite Aid conversions into community pharmacy models.
Ben, can I ask you, can I interject there? So the community pharmacy models, are you going into communities that do not have pharmacies? So is it providing that need? Are you supplementing existing pharmacies? What does that look like?
We look at things from a standpoint of patient density, first of all. We had an opportunity in the city of Owasso for a Rite Aid conversion there that we could do some things with efficiencies on our former urgent care sites and actually have a really optimized for throughput urgent care situation in that particular building, and then bring that community pharmacy presence for our patients, which included additional add-ons like drive-through and delivery within a certain frequency as well. An interesting model really was more recently where we went into a community that was really facing a strain. To answer your question about Owasso or this other community, which I'm going to talk about, which is Flushing in Genesee County, when Rite Aid left, we were getting back feedback from our patients, just the crush on the remaining pharmacies, that there was such a crush and such a challenge and a choke point there, that this was also meant to be a bit of a relief valve to make sure that our patients were being served well. We did an assessment of Flushing as a suburban community in Genesee County, and really realized that a lot of individuals from that area were already making the choice of Memorial for their care, whether it be primary care relationships or even delivering their babies with us. And we had a thought process that we want to honor that trust that's already been exercised on their part and bring things to them. I think we have to disrupt as much as we can in the community hospital space this idea that there's an inevitability to consolidation and people driving farther.
Right.
And so we have rejected that. We brought a multi-service clinic to them. We did the conversion to have another pharmacy option there. We also have primary care presence now. We have an urgent care there for them. We have rotating specialty based on community need. Right now, general surgery is one of those rotating specialties, along with GI.
So you'll have a general surgeon or a GI go out to that community once a week, once a month, something of that nature, see patients there?
That's correct. There'll be and there's going to be some of that driven by also the referral side with the primary care side. Lab and x-ray. So there's just a lot of services there, and it's saying we're coming to you where you are. And the response, I just can't overemphasize how extraordinarily positive the response has been, that this community feels seen, that the dignity of access in their local community is there for them. And it's very validating that our thoughts as a community hospital are what's needed, and we want to look at other opportunities like that. But that's an example of taking a kind of a market, if you want to use that word, and saying, what can we do to add value and drive rural access at the same time? And Memorial is going to continue to push that innovation moving forward.
And how are those clinics doing? Because you started this project years ago. I mean, Flushing's the newest, it sounds like. And I would assume they were coming back to your main campus if they didn't have coverage in Flushing. But you've done this for a while now. And what's been the reception of the community?
Reception's been outstanding. They performed well. I think there's a reason I'm not CEO, because I'm hyper competitive from a grab it and go. I wanted to do 7 or 8 Rite Aids all at once. You know, if it was left to me, right? But I think prudently we look to have proof of the model, and the Owasso conversion to the community pharmacy model was proven successful. And then you look at now the situation in Flushing, which is now on a very sustainable path and doing well.
That's incredible.
And the other part of your question, community reception, both cases, very positive, because we're listening to what their needs are, and we're bringing it closer to them. We're trying to remove barriers to their access to care.
Yeah, Ben, you've been an advocate for rural. You and I have talked about rural. In fact, we talked about opportunities to build some synergies between rural hospitals. I carry that message forward because I'm a member of the Michigan Hospital Association, and the MHA understanding the value that rural brings in light of 150 plus closures of rural hospitals since 2010, in light of 734 hospitals at risk of closing, recent polls conducted demonstrating that those hospitals are at risk in the next 3 to 5 years. There was a need to focus on rural specifically because the big tertiary centers are not interested in taking all of our patients, believe it or not, because they don't have the capacity for that. Patients boarded in the ER for days or weeks isn't good for anyone, and they lack the capacity. So there is a relationship that rural health plays with tertiary centers. You're not doing heart surgery, I don't believe, at Memorial. We're not doing it here at Hillsdale. I'm not going to do it. That doesn't make sense for us. But other niche services that we have are bread and butter. We want to be able to provide the community to get those services here. long story short, you've been an advocate for rural health, primarily because both you and I have grown up rural, so we know the importance of that. Largest employers in the community, so we get the importance of that. But you've been particularly focused on building synergies in a coalition for rural. And at MHA, we just formed a new board, and it's really that Rural Center for Excellence. And Hillsdale is representative. Memorial is representative. Your president is serving on the committee, on the board. Look forward to working closely with him. But in your view, let's talk about rural. Where do the advocacy efforts need to be placed? Give our board a charge. Give us some direction. Seriously, I'm very interested to hear where you would, if you were on that board, if you were seated there, what advice would you give us for where do we start to tackle this issue?
Well, first of all, I want to applaud the energy that you brought to establishing that body. I think that is a wonderful reflection on the part of our state association, that this is a worthy cohort to have a voice. So I applaud that. In some ways, you've been driving through walls, and you've allowed me to be more polite because I know JJ will say it if I don't say it.
We're going to do it.
So I appreciate that a great deal. First of all, I'm excited that this body's been created. Obviously, there's a primary right in front of us focus on the rural health transformation funding side of things to make sure that whatever allowance comes from the state that would be going to rural hospitals is done in a way that's prudent and very user-friendly for member hospitals. So that's an early utilization. But yes, to think longer term, I think there's been some challenges where we've often faced kind of regulatory or even lawmaker assumptions about how rural operates, where you kind of have broad brush assumptions being made. And so to raise awareness and speak to where truly there are efficiencies available, I think about things like technology. It's not just as simple as putting up a new widget, because you have each hospital has its own interoperability challenge.
Exactly.
They have technology vendor relationships.
Yeah.
So to have coherence in an area like that is important. The other is truly a voice on where the biggest challenges are with payer relation issues, where there's just systemic challenges with payers on certain things that larger systems can write off or kind of outscale their way out of. And we have to be far more sensitive to, where, these types of payer things might just be a rounding error for a large system. But in the case of a rural independent, we have to have all hands on deck on some of these changes. Elevating that conversation is important. The hopeful thing that I see, and I hope you've seen it too, is that there is an openness to rural. I think rural should be, in effect, the front door to hospital advocacy generally.
Sure.
Because our stories are more close to the local communities. They're more approachable from a public policy standpoint. And so articulation of those things is another focus I would encourage for the center.
Yeah, I've heard you over the last few years, because you and I have talked a lot about the need to advocate for rural, and I'm going to be calling on you at times to help us lead a task force in specific areas. One of the areas that you've been very vocal, first of all, I appreciate you testified in Lansing. I had a chance to review that. You've done a great job advocating, and I expect that to continue. One of the areas that you focused on and been a very, very big voice for us is in 340B. And our listeners today may not grasp the critical nature of 340B for rural. And I want you to talk a little bit about what is 340B. Can you just give us a thumbnail sketch so the listener today understands why is it in jeopardy? What advocacy efforts are you taking, and what should our listeners across the country? Because 340B just doesn't impact Michigan. What type of effort should we be taking? But take us through the journey, if you would.
Yeah, well, 340B came into being federally during the George H.W. Bush time, and it was a bipartisan initiative, Democratic Congress, I believe, alongside President Bush, speaking to, in effect, the reality that the federal government looked ahead and said we're going to get crushed by social safety net obligations if we are the only funding source for these types of things through Medicare and Medicaid. And so what we'd like to do is provide some type of a benefit to our social safety net hospitals like Hillsdale and Memorial through a more profitable part of the healthcare ecosystem, in this case, pharmaceutical manufacturers. So It in effect mandated a discount application for the rate in which hospitals like ours are able to receive medications from these pharmaceutical manufacturers to serve our patients in these, in our case, disproportionate share Medicaid populations. We're able to access that savings, and then we're able to utilize that difference for some of our operational needs to keep our doors open and to keep serving the communities that we're in. So in the case of Memorial, and I'm sure Hillsdale as well, it is a fundamental piece of our ongoing financial sustainability, truly keeping our doors open. And if you think about some of the service enhancements that we've been able to do, preservation of our obstetrics unit, we're now up over 500 births a year in our area, our only birthing unit within 25 miles. That cancer center, which offers oncology and a radiation oncology partnership, you'd have to drive 25 miles, 20 years ago for basic chemotherapy services. These things came about primarily because we were able to have that benefit afforded. In recent years, what we've seen, unfortunately, is that the pharmaceutical manufacturers are trying any method or means they can to both redefine what the program is, to do a death by 1,000 cuts, to go after the discount allowances, and they've had some success with federal regulatory bodies and things of that nature on their interpretations. But we've seen a constricting of some of our ability to follow patients to where they actually are serviced by contract pharmacies, as one example. And these are multi-million-dollar implications for us. Now, again, as pharma continues to be a highly profitable piece of the healthcare ecosystem, I go back to the fact that there's just different purposes to these different pieces of the healthcare ecosystem. I don't, dissuade the fact that the pharma manufacturers have a place, and pharmaceutical research and innovation has a place, but they also are structured differently as for-profit, shareholder-serving organizations. We, as nonprofit healthcare providers, have a fundamentally different purpose in providing that direct care, having the providers, utilizing their professional judgment in diagnosing and treating, and there seems to be a desire to have this equivalency on the part of pharma where they're providing the healthcare, and therefore they have some say into our side of the equation, and that's been very tough to hear in this 340B debate. But at its core, that 340B program is an augmentation of the social safety net required for hospitals like ours to really be sustainable and tie into all different pieces of our operations.
Ben, help me understand, because you did this in the legislature in Michigan. There's still a misunderstanding of what role the state plays in 340B. What is their limited role in 340B today?
Well, really, without the contract pharmacy changes that came down, there really wouldn't be a state implication here. What occurred was that there was a federal move that allowed for constrictions to be interpreted, restrictions to be put in place potentially by the pharmaceutical manufacturers. Obviously, that's been contested. But what that brought up was the a true contractual situation of is there a right for this private entity to come in and say, no, we're going to go and disrupt these contracts that these health providers have with their contract pharmacies. The state, other states started looking at legislation and passing legislation that restored the ability to have these contracted relationships, so we could serve our patients where they live, so that we could make sure that the pharmaceutical supply chains accurately represented, and that where that drug's formally being dispensed, which might be a hub and spoke kind of a distribution model that may not be in our immediate area, but it's serving a patient in our immediate area, that's reflected in the program. And it came squarely into the laps of the state legislature as a potential piece of state legislation, and all the interest grouped and tremendous pharmaceutical spending has avalanched in since. Throwing as much as possible at the wall, because it's a lopsided issue. Every day that goes by, the pharmaceutical manufacturers are 100% okay because they're maintaining that, they're retaining that profit for that share of the 340B program. So delay is the chief tactic.
Yeah, absolutely.
If I can just get something in front of people that gives them pause, and we've seen that delay unfortunately be successful in the last 2.5 years, let's say, and that pain is continued as far as our diminished ability to have that savings realized for that particular patient.
Well, thank you for your advocacy in that, because when you lift your voice, you're lifting the voice across the country, not just the state of Michigan, to say, Big Pharma, you have your place. Interestingly, I was reading a statistic, and I'm not going to quote the number because I don't recall it, but it was a high incident rate of visits to Mar-a-Lago by Big Pharma. And there's a reason Big Pharma is visiting Mar-a-Lago. There's a reason that Big Pharma is visiting Washington. There's a reason that Big Pharma held a conference for state legislators not too long ago. And the reason is to, quote unquote, provide their perspective on the 340B program, which is healthcare hospitals. We're flush with cash. We're not returning this. We're investing in things we shouldn't be investing, which is furthest from the truth. But that comes to the notion of advocacy, because they're hitting it hard, and they're knocking on doors. What would you say, because this is a national podcast, by the way, just now syndicated for one of the top podcasts on the Healthcare Podcast Network. So we have a lot of listeners across the country. For those listeners who say, where do we get started in advocacy? Because there's a lot of rural hospitals that they don't have a Ben. It's me. It's the CEO. It's the CFO. Where do we get started? So I want you to talk about the importance of advocacy for rural health. Where do they start? How does the process begin? Do legislators really listen to us? I want to have a conversation about that as we conclude today's podcast, is talk about what we can do to unite as healthcare.
Well, I think the first thing that I encourage anybody to do, and particularly rural hospitals, community hospitals, is to own your stories. You're likely doing some things in the communication space and the public relations and marketing space that really is about attracting and retaining patients.
Yes, that's a great point.
But if you think about advocacy as a secondary layer, all you're really doing is looking at another specific stakeholder group, in this case, elected officials, ready ambassadors. You're saying, well, how do I communicate with that particular group? That's an advantage that pharma doesn't have.
They don't.
They don't have patients in the way that we do.
No, they don't.
They don't have the community, and they really don't have very high favorability ratings.
Right.
So you look at that and you say, okay, well, we need to own where we are excellent. And where we are excellent is in the provision of care and the sharing of the stories effectively about those cares. Now in this case with 340B, there should be that connection point on, because of this program, we are able to do these things with, like in our case, we have an initiative at Memorial where we're able to bridge cancer treatment before prior authorization as a part of a 340B benefit, that a patient can immediately begin treatment versus having a delay waiting for insurance approval, as one example. But there's a lot of stories like that where you can say that these things have tied back into the ability to provide care. And I think that most organizations can look at some of their strategies perhaps for patient retention and patient persuasion and say, how would we do that differently with our local elected officials, our state elected officials? The elected officials are always going to be, I hope, open door to have those conversations. And the more that you can be in front of them with people-facing realities, I think the more you can differentiate with some of those larger interest groups that may just come in or fly in, literally fly in, fly out. There's just a personal touch you can have with your local legislators that I think is a superpower that needs to be exercised by every single rural hospital.
Yeah.
And if somebody's listening that's a large system that has rural hospitals, that means that rural hospital should have a community relations liaison, somebody that's in there, that's staying embedded in that community, building those relationships. It doesn't have to be a full-time advocacy type person like my position. If you're a smaller type of a system, but to have that voice and that constant kind of connection point to the communities. I think that's one of the blind spots that we've seen with the mergers and acquisitions is just a lack of recognition of just how important it is to stay connected to the communities you're serving.
Right.
It's often missed.
It is.
And so that's why you see such an energy level from the remaining independent hospitals, because we are so responsive to that.
We pick it up.
And we don't have that margin of error.
We do not. Great perspective. So I'm going to transition a couple questions before we conclude today. You've been in healthcare now, entrenched in it. You've always been involved at some level, almost 4 years. And I want to ask you this. In today's environment, which is tumultuous, we got HR 1 happening very soon. We've got average commercial rate going away, which has brought us millions of additional dollars. We're going to have to find somewhere. You've got changes from payers. Blue Cross is, negotiating or quote negotiating with hospitals. You're hearing a lot of contested negotiation, a lot of challenges. You have federal and state legislators saying waste, fraud, and abuse. A lot of challenges for us. I'm going to ask you, as a senior leader, what's keeping you up at night as you think about all these things? What really is what are you worried about today?
I think you articulated it. I think if you're in the advocacy space, certainly in your space as CEO, you're not thinking about, the immediate, you're thinking about 5-10 year forecast. And where I have a nervous energy is about trajectories, because when I think about the stacked behavior of kind of where the payers are and some of the things that are coming in as far as increasing complexities, it almost seems like mergers and acquisitions are considered a foregone conclusion, even by some friends in the sector, where that at some point there's going to be some Godzilla and Mothra matchup between these massive insurance payers and massive healthcare systems. And I feel like that is losing such a heart of what healthcare could be if that's just a foregone conclusion. Obviously, I reject that.
I reject it. And
I think we should be doing what we can to differentiate, to show why you absolutely need to have that community, hospital segment.
Amen. Preach it.
But there's a certain ambivalence about it. There's also, in some cases, a willful ignorance where those that I think have had good motivation, good hearts, they just aren't hearing things right now because just the way that things are kind of stacked up. There's not a lot of opportunity for true conversations on things. That keeps me up, so trying to understand how we get to a destination. But I think the biggest for me is that each of these things that is happening in the payer space is a dehumanization of the healthcare experience. We're taking away the relationship between patient and doctor, which is still universally seen as so precious and so universally. It's not partisan at all.
No, it isn't.
And yet the structures and systems are doing everything possible to rob the human connection from that relationship. And turning the tide on that is something that keeps me up at night.
All right. On the other vein, what are you excited about in healthcare today? Whether it's specific to Memorial, something you're doing that you're allowed to talk about, or just what's encouraging for you right now?
What's encouraging for me, the team at Memorial inspires me every day. But again, I go back to Flushing, and there's a story like that where, if you can deliver community individualized healthcare to a community and have these individuals and these people feel seen, there's still a place for that, and that people want it. And I think that to me starts to well up in the standpoint of, people power, whereas there's a vein for community engagement, I think, that has not been realized yet, where perhaps we can harness that favorable relationship and really start building, back from where we've come, and create some sustaining community relationships. That's inspiring to me, to work on projects like that, to work on, public policy where there is such an innovation component now, where we see there are some really good things with technology and healthcare. There's some exciting things in that space, and to see those things coming to fruition in the small town where I live is extraordinary. To see that we can have a robust organization like Memorial in a town like Owasso, and to say we deserve that it's not a foregone conclusion. This has to be a failure. It gives me hope that there's a way that we can spark a renewed interest across different economic strata and different communities to get people thinking differently about things, and just restructuring some of these models.
Agree. The leadership of your hospital, incredible. The work that they're doing, which you're part of, but the global vision of what your community needs, so critically important. There's very few of us rural independent hospitals remaining, and we just heard yesterday, at the time of this podcast, that another hospital's closed in Michigan. Sturgis is closing their doors. And we're hearing more and more of those stories. And this is why we have to be an advocate, a voice. This is why we have to tell our story. And I think, to your point, it is the number one priority. Tell the story. The voice of the patient, the voice of the hospital. What is our economic impact to the community? Some of that gets lost, but tell the voice of the patient and their perspective about what local care means to them. It means, in an OB case, it's an abruption that happens. They're not driving 50 miles.
That's right.
It means we're saving babies and moms. It means for the individual, we say time is tissue, that when they're having a stroke or a heart attack, we get them stabilized until we can get them to the tertiary center. So I'm very proud of the work that you and your team have engaged in. You have a great vision. They have a great leader in you. Very, very appreciative of the work that you've done in Lansing. And I guess, for a segment we always do is because it's a national podcast, I get emails frequently. What should we do here? Our hospital's struggling here. What advice would you give us? We created a segment based on some of those questions. And that is for the new leader, or let's just say a leader today is going through all these tumultuous times and having the discouragement that they have. What piece of advice, what sage advice would you give them today to keep on keeping on? Because it's lonely at the top. And it's a challenge when you're facing community backlash, staff backlash for wages, and all of the factors of unionization. And then you deal with a legislature who's got their claws in you because they feel it's waste, fraud, and abuse. And then you got big pharma coming at you. And then you got payers who don't want to negotiate fair rates with you. We're getting hit from every direction. That can be a challenge to leaders. What sage advice would you give them?
From my experience, I think that Memorial's team continuing to have the mission right in front and center. Every discussion, every meeting has been centering, because often, the discussions are about threats and about potential challenges. But when you think about that mission and you have the right people too on the team, you consider that culture fit for the leadership and the team that you're organizing, you can do amazing things. But it's also self-perpetuating from a motivation standpoint. And leaders in particular need to not isolate themselves,
right,
and make sure that they're walking the walk of communication as much as they're talking it, because oftentimes you see that being put on individual shoulders. There's a reason for the team. And I'd say that, the team.
Absolutely. Great perspective, Ben. It's always great to have you in the studio. You bring such insight. Hope to have you back again, share some of the great things that are happening in community pharmacy, community engagement. Hopefully read your name in the lights of some great and innovative things that are happening. I'm going to tap you for some assistance with our new committee, the new board, because we're going to need perspective like yours to bridge the gap between local hospital administration and the state and federal government, so we can have those conversations. So I look forward to that into the future, Ben.
Always a pleasure, JJ, truly.
And thanks to our listeners for tuning in to Rural Health Today. Catch our next segment, Rural Health News, to stay up to date on the current state of rural health wherever you get your podcasts on Mondays. And don't forget to check out our latest updates and resources at Rural Health Today at ruralhealthtoday.com, and make sure you've subscribed so you never miss an episode. Until next time, remember, Rural Health Strong.